Everyone, welcome to the first academic grand rounds of this academic year. I hope everyone had a wonderful summer. Back to school went very well for those of you who have school-age kids. I know Nathan's kids had a good start to school this year. I want to introduce you guys to our presenters this morning. So we've got Austin Pereira and Prem Nakani, who are senior residents in our ophthalmology program at the University of Toronto. And we've got Nathan Chowdhury, who's an internationally recognized vitreoretinal surgeon who is affiliated with both the University of Toronto and Harvard. He is considered a thought leader in retinal imaging and the diagnosis and treatment of rare disorders of the retina and vitreous. And I've often seen him speak at national and international meetings on this topic, and he's always very engaging. He's one of the pioneers of OCT imaging of the peripheral retina and is actively developing devices for imaging the retina and vitreous using non-invasive technology. In addition to his speaking, he's published several books on these topics, including retinal medicine and wide field imaging, and serves with multiple societies, including the American Society of Retina Surgeons, the Canadian Retina Society, and the COS. So Nathan, thank you again for making the time to present to us this morning. It's truly a pleasure, and I welcome you to open the Grand Round series for this academic year.
Thanks, everybody. Thanks for inviting me. I appreciate the opportunity. I'm going to just share my screen here and we'll get started. All right. That should be visible to everybody. All right. So thanks to everybody. So, I am, as we were just talking about, imaging has been a key interest of mine, and I've continued to evolve my research and practice around a lot of these new technologies. And so I thought we'd go through something exciting and sort of not so stressful as we start off the beginning of grand rounds for the new year. But look at imaging signs that we see on our day-to-day imaging and how they relate to patients' diagnoses and prognosis. A lot of this is very similar to what we see in the world of art. And I think the art of observation is the one art that all of us are really focused on, at least during our training years. And this Da Vinci quote always seems to ring true with me, learn how to see and realize that everything connects to everything else. And I think in ophthalmology, that's very true. But we don't have to look too far for signs. We've seen signs in art in the history of the world for years. And this is the famous Picasso painting during the Blue era called The Old Guitarist. And, with newer technologies and infrared imaging and even just the journey of time, we're starting to learn more and more about some of the signs and some of the key things that have been left in some of these artworks from the past days. So if you look at this particular painting, it was found with the aging of this particular painting and with infrared technology that there's actually another face within this same painting. So hopefully you guys can appreciate that, but you can also look it up on your phone, The Old Guitarist. And there's that face imprinting within the actual art. Another example of this is with Jan van Eyck, and this is a picture of a man and his wife. And Van Eyck was painting this painting, but he left a little third-party footprint in this painting. He's actually in the painting in the mirror, and he drew himself into the painting. So, this idea of how we look at images and learning to view the world and look for clues and seeing what's beyond is a critical part of what we do every day. And lastly, I thought this was interesting. I saw a few of us had gone to New York over the summer, and this is a Piet Mondrian, and this is a piece of art that was originally thought to be just a piece of abstract art that this artist developed in the 1940s, but it turns out his intention was to draw the New York City cityscape. So with all the bus stops and with all the streets and all the stoplights. And so, sometimes we don't really know their intention of the artist, but there's often hidden clues in their works. So we don't have to go too far to see the clues and the efforts that have been put into ophthalmology. This is the first fundus photograph from 1899 from Dimmer. This was done in conjunction with Zeiss and Nora Dinson, and they were developing this large footprint camera. And over the years, we've seen an evolution of retinal imaging. Obviously, we've gone from that time of Dimmer all the way to where we are today, where we have great tools that give us a wider perspective. And then we have this multimodality approach. And so as more technology has come into our hands, we're seeing the retina and the eye in ways we haven't seen before. And some of these footprints and clues towards diagnoses are right there in the images for us to look at. So let's take this forward and look at some applications. I'm going to give you guys 5 cases. We'll go through these 5 cases in the spectrum of these retinal imaging signs. So here's a 50-year-old patient, chronic rheumatoid arthritis on Plaquenil. blurry vision, 20/40 OU, and here's what we see on her imaging. So we'll keep it somewhat interactive. Are there any PGY3s or 4s that want to weigh in and comment on what they see on the OCT?
So maybe we'll get someone in the room at the PGY4 level.
Sure.
Not all at once, though.
So I'll set you off a little bit there. So the autofluorescence images that you're looking at, look at the RPE, and you can see these dark ring-like structures in both maculae, as well as a hyper white autofluorescent ring in the surrounding region. So this is a very symmetric phenomenon. It's occurring obviously bilaterally, and there's corresponding changes not only in the autofluorescence, but in the OCT. So obviously, most of us look at this OCT and say, "Yep, it's abnormal," and you can be very nerdy and granular about what layers are abnormal. But this is a very classic feature for a diagnosis that we really all cannot miss. So let's take it forward. Here are some other examples of that same autofluorescence phenomenon that can happen in this particular circumstance, and you can see that no two eyes really look identical, but the general patterns are somewhat similar and need to be addressed and not missed. So basically in this phenomenon, anybody know the diagnosis? Want to shout it out?
And then let's get a PGY5 in the back. I think I see Marco there. Let's get some ideas, a differential going.
So it looks like a bullseye maculopathy, probably from plaquenil toxicity, would be my leading diagnosis.
Great, perfect. That's correct. So when we see plaquenil toxicity or even chloroquine toxicity, there's sort of an evolution of this phenomenon, which gets us to that flying saucer sign that we're going to be talking about. And here's a very subtle case of a patient with early plaquenil toxicity, and you can just appreciate some outer nuclear thinning and ellipsoid zone thinning that's starting to happen, and that prominence of that area of the ellipsoid zone just under the fovea in that sort of flying saucer sign. I can tell you, this subtle change is enough to be missed in a regular busy office on any given day of the week. And so that's why I think, as we evolve our tools and evolve artificial intelligence, we'll be able to use algorithms to catch this early. So there's that example of that outer nuclear atrophy. Here's how it can progress. You get more ellipsoid zone atrophy. You can see that there's this sort of moth-eaten appearance, right? Little fine dots. Everything is starting to separate from its interdigitation. And then as we go further, you start to get more of what we saw in the beginning of the case, that RPE atrophy, and then obviously some backscattering through the choroid. We get often asked about the brightness of the choroid in these areas where there's this shadowing. This is a function of the RPE being lost, and as a result, the OCT signal is being reflected right back by the vessels. Henceforth, you get a very clear view of the vessels versus the adjacent vessels, which are not as clear. So that's that phenomenon happening there at its extreme state. So, we don't want to be catching this condition so late in the game. We want to catch it really early. And so this is another key feature with respect to plaquenil screening. And, all of us at the minimum are charged with the task of being good comprehensive ophthalmologists, particularly at your stage. And what you can see here is that, it comes in a variety of flavors. It's not just central. You can have paracentral, as you can see in figure B. You can have a mixed phenomenon here where you get both central and paracentral and pericentral as well, where it's really far in the periphery. And if you look at the autofluorescence panel D here, you'll just see this sort of wing-shaped wedge of RPE damage. And what we've actually found, it's been published now and confirmed in larger series, is that Asian eyes tend to develop their RPE, outer nuclear ellipsoid zone atrophy and thinning more peripherally rather than centrally. So getting that full visual field is still the most useful way of determining and detecting plaquenil toxicity. Because most of us have an OCT in our office, and the line scans and the patterns that are chosen may be variable, but until you're getting, full-blown wide field OCT on everybody, you may miss these Asian eyes. So the take-home point is Asian eyes, make sure you realize that the peripheral portion of the retina may be affected first and get a visual field. So not to belabor it, obviously flying saucer sign was referred to as its early toxicity can be asymptomatic. The key points here really are the second bullet. Toxicity up to 5 years is super low, so 1%. But as soon as people have been on medication for 10 years, it's about 2%, and then it goes really quickly up to 20% at 20 years. So something we don't want to miss, one of the most litigated areas of ophthalmology, and a drug that's not going away, and it works very well. So we have to just be vigilant. Okay, second case. This is a lady, a 36-year-old lady with a central scotoma, and she had Hashimoto's diagnosed about 4 years ago. Anybody want to try to describe this phenomenon, or if they know the sign, just shout it out.
All right, let's get a little description from one of the PGY4s. I can't see who's there, but maybe we can get someone to volunteer.
So here we have a OCT macula, and the vitreous looks fairly normal. The inner retina has good lamination, and then in the outer retina, there's relatively homogeneous hyperreflective material at the level of the outer nuclear layer, and there's these kind of finger-like almost projections going into the more the inner retinal layers. And it looks like the ellipsoid zone is disrupted in this area as well.
Good. I'd say it's a pretty good description, a little subretinal fluid there as well. I agree with all of that. So does that make you lean towards anything? Do you know what this sign is and what it might represent, what the diagnosis might be? So what's unique about these signs is that these signs will often narrow you down to 1 to 2 diagnoses. And so that's why it's meaningful in our world to, yes, with all the nerdy imaging vernacular that we use, appropriately look at scenarios where we can take advantage of what we're seeing and help the patient in terms of making that diagnosis. So here's some more flavors of the same phenomenon. This is from a paper that was published in 2013. This is obviously the fundus in panel A, in a fluorescein that shows leakage at that location that corresponds to the area that you were referring to, with those finger-like projections, and then you can see the cuts through this particular area. Anybody feel like they know the diagnosis? Okay. So this is pitchfork sign. Okay, it looks like a pitchfork. It's a distinctive OCT finding that's seen in inflammatory choroidal neovascularization. Okay, and so it helps us to distinguish between 2 conditions, which are punctate inner choroidopathy, which we see in that myopic young female often, as well as multifocal choroiditis, which has an association with TB. And these 2 conditions are conditions where if you see this type of CNVM, this pitchfork CNVM, you can be pretty sure that you're dealing with an inflammatory CNVM, and it's likely one of these 2 conditions versus any other cause of a white dot syndrome or other causes of choroidal neovascular membrane. And this has to do with the inflammatory nature and the currents within the retina that are moving the tissue. And again, so knowing that this is a inflammatory CNVM, you can introduce the idea of potentially using steroids to treat the CNVM, not just anti-VEGF, because inflammatory CNVMs respond to steroid therapy. All right, we'll go to the next one. This is a 62-year-old male with diabetes and hypertension, pretty common to see in our practice. Here's the pseudocolor imaging. Here's the autofluorescence. Anyone want to comment about the autofluorescence?
Maybe we can get another PGY5, not Marco this time, but we'll pick on someone else. Hard to see who's in the room.
Go ahead,
So
Ellen.
this type,
Ellen's gonna go.
Thank you, Ellen.
So in these autofluorescent images of the right eye in inferior arcade, I can appreciate some specks around the fovea regions, and also it seems that it's very granular, and more obviously on the left side, there is hyper autofluorescent signals around the fovea as well.
okay, good. Yeah, so it's very subtle stuff. And so I think, when we look at autofluorescence, the terminology that we want to be using is hyper, auto, hypo, auto. So hypo being dark, hyper being bright. Obviously, as was mentioned, these focal, small focal, hyper and hypo autofluorescent areas are the only noteworthy areas here. So here's the full multimodal perspective now, and you can see the OCT in both eyes. Anyone want to take a stab at either to the description or the sign and or diagnosis?
I can go. There's an intraretinal cyst with an ILM drape, and possibly there is also loss of the outer retina. My diagnosis in this case would be MACTEL type 2.
Okay. Anyone else? Good. Okay. So yes, this is MACTEL type 2, and this is ILM drape. And that ILM drape phenomenon refers to, if you look at the ILM, it just looks like it's sort of providing a tinting or just a brief cover over the retina, which is atrophied from below. On the left here, you'll see an OCT angiogram, and you can see the vessels sort of diving down from the superficial layer down to the deeper layers. And that's a classic sort of appearance for what we see with macular telangiectasia. Macular telangiectasia specifically is a condition where neovascularization can develop from the superficial vascular plexus as well as the choroid and connect and give you a CNVM. In these cases, that's not what's happening. When we refer to these black spaces within the OCT, we refer to them as clefts. And so I would avoid the term cyst only because cysts for all of us imply fluid, particularly to our plastics colleagues, right? And so since the tissue here is degenerating, it's not just filling with fluid by default, it's a vacuum, basically just cavitary or schitic in nature. That's what thesis cavities are as well. So that's a term that I would use here, but this classic ILM drape is very, very key and unique to this disease based on the way the degeneration actually occurs. So as we all know, MACTEL type 2, there's capillaries in the foveal or perifoveal region where you get outer loss of the outer nuclear as shown, ellipsoid zone, and we get this cavitation. And the term cyst has been previously used, but we're sort of veering away from that given the connotation of fluid. And you can see that ILM draped over the affected area. And, 60% of these patients on average have visual acuity of 20/50 or better. I can tell you that you are all seeing these patients in practice. Occasionally they're misdiagnosed as diabetics. Occasionally they're misdiagnosed as having AMD, but it's a very different disease. The incidence of CNVM is very low. It's probably 5 to 10% or less. And there is some therapies that are being developed now looking at the complement pathway to help to stop the progression of this condition. All right, here's case 4, run-of-the-mill guy, 67-year-old PDR with PRP history and diabetes, hypertension, the works. Here's the OCTs. Anyone want to take a stab at describing these?
Maybe we'll go with one of the PGY4s.
There's no wrong answers in teaching sessions.
Just a description.
Okay, so I'm BGY5, but I would just
Sure. Oh, that's Safwan. That's the guy I was telling you about.
Okay, so this is an OCT of the right and left eye with the vitreous looks clear, but in both eyes I would see there is disorganization of retinal layers, and as well as it looks like there's a few cysts in the like intraretinal cyst as well. Also notably, there is parafoveally, there is loss of ellipsoid zone. This could be related to macular laser that happened in that area. And there's also thinning of the retinal layers.
Great. That's a good description. I agree with a lot of what you said there. So yeah, the key thing really that's highlighted is this eye looks not well, right? A lot of the layers look atrophied and thin. They're sort of indistinct. And then there are these few black spaces which were labeled as cysts. And these are sort of microcystic changes that are seen with chronic neurodegenerative processes. This atrophy that was alluded to earlier was not from prior laser, but just from the chronicity of this patient's edema and disease. And so basically what we're looking at is what was mentioned earlier is disorganized inner retinal layers or drill. So if you look at this example here, you see that the lamination that we normally see with layers where you can tell, the inner nuclear layer from the outer nuclear layer from the ILM, it's kind of indistinct. And this phenomenon, obviously, as you can see, compared to a normal, we lose that lamination. This phenomenon was described a bunch of years ago now by Lloyd Aiello in patients with chronic DME. And we really just see that over time, you get this neurodegenerative process. And the more widespread the neurodegenerative process actually is, the worse baseline visual acuity patients have. So, here you are, you're in clinic, it's not surprising that you're seeing a diabetic. You're not blown away because you're going to see the fundus. That'll be the telltale. So what's the imaging sign? Well, just the sheer fact of a patient having drill in general allows you to counsel them better about what vision to expect, what kind of future prognosis their vision may look like, and then also their response to therapy as well. So these patients don't respond as well to therapy, and their retina itself is so disorganized that their long-term prognosis for even losing vision is so significant. So definitely a sign not to miss. And, again, this was described in 2014. And since then, we've actually seen the phenomenon of drill in other conditions. So including from diabetes to retinal artery occlusions. You can see this in MACTEL and even chronic ERMs. And so the greater the extent of that drill, the worse their baseline vision, especially in diabetics. So, keep an eye out for these abnormalities. Our technologies are very good these days. We can actually differentiate layers quite well. There's no excuses to miss some of this stuff, but when you see that sort of muddied, indistinct retinal layer phenomenon, you want to be thinking about drill and what the prognosis might be for that patient. All right. This is a 65-year-old female, just reporting unclear vision with a history of hypertension. Here's the multimodal imaging on this particular patient. Let's have somebody take a stab at that.
Maybe we'll go PGY3 this time. Guys, not all at once.
Answers are on the screen.
It's hard to hear whoever that is.
Okay, well, so let me kick you off a little bit. I mean, obviously we've labeled for you that there's a yellowish area of retinal elevation in the fovea, which has some leakage associated with late angiography. And then the OCT is really what I want you to focus on. So can anyone point out anything that's unique about this particular serous detachment compared to what you normally see in your practice or in clinic?
I know you guys have seen RDs, so. All right, maybe we'll go to one of the seniors. 4s or 5s, anybody want to help?
So let's help you along here. So this is a bacillary layer detachment, okay? And there's nothing wrong with not knowing it because that's the whole point of these lectures, right? Is that to bring to the forefront new ideas that we are all seeing in observations in our patients. So a bacillary layer detachment is what's depicted here, as opposed to a traditional serous detachment or a serous PED or a fibrovascular PED. The entire layer, in the case of a PED, is elevated, that one focal area. When you have a serous detachment of the retina, you'll see the entire neurosensory retina is elevated. In a bacillary layer detachment, the fluid actually that's dissecting through the retina is between the photoreceptors. So you get a fracture between the photoreceptors at the myoid layer. And so basically, when you think about photoreceptors, they're interdigitating, just like your teeth. So if we were to separate that interdigitation and have one half of the photoreceptor attached and one half separated, that would be this bacillary layer detachment phenomenon. And it's been seen in a variety of conditions like VKH, AMD, other inflammatory diseases, as well as in macular neovascularization. So it's a common phenomenon, but it is unique in that it is a biomarker for poor visual prognosis, right? So sometimes our biomarkers are specific to a disease like flying saucer sign or pitchfork sign, and sometimes they're just more prognostic in nature, which is in the case of drill, as well as in the case of bacillary layer detachment. And of course, this phenomenon does portend the increased risk of subretinal fibrosis, which you can see particularly in neovascular AMD. So just to wrap this piece of it up, as we get into our two cases, I think detailed observation skills is something that we have to continue to cultivate, even us as attendings, and obviously through your training. You do have the responsibility of staying on top of the imaging technology. And most importantly, really asking questions, right? You're in clinic. What am I looking at? Why does it look that way? What does it mean anything? I think looking for these specific signs is helpful as they're described, but in our offices, we're seeing images all day long, and all of these signs and observations have come out of a fundamental question. So continue asking questions. And of course, reproducible signs do have have a meaningful connection with prognosis and not to be missed. We've got all the references for this talk in this QR code if you want to QR your way to those, because they are seminal papers. And I'll open it up for discussion. Thank you.
Well, that was fascinating, Nathan. Thank you very much. I think one of the key points there is just you got to be looking for some of this stuff. I think it's very easy to, as you said, especially in a busy clinic, not just a retina clinic. I mean, that plaquenal patient may show up in a general ophthalmology clinic, and very easy to miss that. Also interesting, the comment you made about the Asian eyes and plaquenal. So you're suggesting a 24-2 for those patients. Are you also getting a 10-2 for those patients, or just 24-2?
So that's a good question. The Academy still says that 10-2 obviously is superior. And then we know that this is the case. I think the issue with the Asian population is that we are pushed to do that 24-2. So, you may decide to do both if you feel that's the better option for you in those patient types. But just the sheer fact that we could be missing it in a whole section of patients is, it's a bit scary.
Okay. Well, I mean, you learn something new every day. I leave with something that's gonna be practice changing for me. So thank you. The question here from the chat: how can you differentiate pitchfork sign from onion sign? And I'm partly wondering if this is a joke from Austin, and I'm partly wondering if it's a real question.
So it's good that Austin asked that question, because the best way to answer that is, Austin, what's onion sign? Tell us what you understand it to be, so we can talk about why it's different.
Just from the chronic exudation.
Say
Yeah,
it
I
again.
think it's from chronic
Chronic exudation. Yeah, so the way you can distinguish is pretty much those finger-like projections. That chronic exudation with onion sign, as it's described, that we could probably include that in a subsequent signs lecture, but it doesn't have those same finger-like projections that you see with the pitchfork sign. The hyperreflectivities are more like asteroid hyalosis that are emanating from that onion sign. So I think that's just talking about it probably doesn't help the audience because they can't visualize it, but the pitchfork piece is key, the tentacles.
All right, thank you. So who's up next? Remind me, is it Austin or Prem?
Austin can go. Yeah, go ahead.
Okay, Austin.
Can you see my slides well there?
Yes.
Okay, perfect. So thanks, Dr. Chowdhury, for the opportunity to let me chat today under your grand rounds. My name is Austin. I'm one of the fourth-year residents. I'm going to be presenting a mystery case and having some tangents to describe some new multimodal imaging that we have at our use in ophthalmology. I have no financial disclosures. So a patient presented to Dr. Chowdhury's practice, a 55-year-old woman who was referred by her optometrist for a persistent paracentral scotoma for the last 2 weeks. She described it as more of a graying of her vision, and she isolated it to her right eye. So it was only persistent when she covered her left eye or with both eyes. Her right eye was the one that was affected. She denied any other symptoms, including flashes, floaters, visual field deficits, pain, GCA symptoms, and a review of symptoms was negative. She was a very healthy patient who had no past ocular history. And astutely, this woman came in and drew out a picture of her scotoma. So when she covered her left eye, or when both eyes are open, when she covered her left eye, her right eye saw this paracentral kind of cloud-like scotoma, which spared her central axis, which was in the supranasal portion of her right eye's visual field. Though her vision was still 20/20, and importantly, there was no REPD. Her slit lamp examination was grossly normal other than early cataracts. This is her fundus photography, and maybe PGY2, like UofT, do you want to take a stab at describing these fundus photos?
Sure. So color fundus photos of the right and left eye, starting with the disc. The discs look normal. The vessels on the right look normal, and the left eye maybe a bit tortuous. Moving to the fovea and macula,
it looks maybe the foveal reflex looked a little bit different on the right versus the left. Maybe a bit depressed on the right, and overall the retina looks a bit tigroid.
Yeah, perfect description. I would agree. Need a bit of tortuosity in the left eye, but I think it's more of a red herring. But really, the key here is that pretty grossly normal fundus examination, other than maybe some blunted foveal reflex in the right eye. When you use biomicroscopy with a 90D lens, you can see some RP changes, but really a relatively grossly normal fundus examination. And here we have our swept source OCT macula images, and only one person can really see there is Ryan. Ryan, want to take a stab at describing these OCTs?
So we have OCT macula of both eyes. The vitreous looks normal. There's some vitreomacular adhesion, but the contour of the fovea looks normal. The inner retinal layers look fairly normal. The outer retinal layers, maybe the transition from the outer plexiform to outer nuclear layer is a little bit less clear in the right eye, and maybe it's a bit thicker in the right eye. The ellipsoid zone looks fairly normal. I'd say grossly looks fairly normal, maybe just a little bit of asymmetry between the two eyes.
Yeah, and this is a perfect description and really kind of speaks to Dr. Chowdhury's recent talk on being very observant on your OCTs. But if you look very closely, the internuclear outer plexiform layers are a little bit more thin on the right eye compared to the left. And really the sign of that is a larger kind of distance or diameter of the outer nuclear layer. So looking back on the OCTs that Dr. Chowdhury showed, the outer nuclear layer is much larger. And this is because more of the internuclear outer plexiform layer atrophy. So very, very subtle, but great pickup, Rye. So let's review some retinal vasculature anatomy before we go on. So the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layers are all supplied by what's called the superficial capillary plexus, or SCP. The internuclear outer plexiform layers, which may be affected in our patient, are supplied by the deep capillary plexus. And both these plexi are branches of the central retinal artery. The outer 1/3 of the neurosensory retinal RPE are supported by the choroid. And we can't forget about our venous system as well. The superficial venous plexus supplies the inner retinal layers, and the deep venous plexus the outer retinal layers. And the DVC is what is preferentially affected when we see those patients with retinal vein occlusions, as it's the principal venous outflow system of the retina. And this is highlighted beautifully by a study by Freund et al. On the right-hand side. So as everyone really kind of contributed, we had a 55-year-old healthy woman with really no past medical occurrence, subjective paracentral scotoma, no intraocular inflammation, normal no RAPD, and as Yusuf and Ryan said, grossly normal fundus and a kind of thin internuclear outer plexiform layer. So based on these findings, what is your next step? Would you want an OCTA, IVFA, neuroimaging, starting steroids urgently, or maybe something else?
Thank you, Austin. We'll give that just a minute to run for the online audience. It looks like you got a bit of a split here, so I'll share the results with you.
Awesome. Yeah, so definitely a split, which we want for these discussions. Happy no one jumped to neuroimaging just yet, but yeah, OCTA or FAF or IVFA are the main choices. For our patient, because we still wanted to get some more information, didn't want to be too invasive, we decided to go with OCT angiography. Now let's just review OCT angiography and approach and where to begin when we look at these images. OCT angiography is a non-invasive imaging modality that uses 100,000 A scans per second to image the retinal and choroidal microvasculature. It does this by acquiring images over a length of time, comparing it over the time to see the flow rate of blood vessels, and it can do this in a three-dimensional manner. And it does not require any intravascular dye, which is a large advantage compared to intravenous fluorescent angiography. And this is the typical Zeiss OCT angiography printed that we'll see in University of Toronto and most of our centers that have Zeiss OCTs, that you have this segmentation, 5 principal layers: superficial, deep, avascular zone, choriocapillaris, and choroid. The key for us is to always delineate what preset map, which you can see here as number 1, that you're examining. Typically, it prints out the entire retina, an en face of the entire retina superimposed, but it's very crucial, especially in our case, which we will see, to delineate which preset map you want to look at. If you think there's a CNVM, you may want to delineate the choriocapillaris or outer retina. And in this case, you may want to do something different based on where our pathology is. The advantage is it's non-invasive, rapidly acquired, and you have improved vascular detail, which you can see, for example, on the right here with the radial peripapillary capillary network, which can now be visualized. But always there's some disadvantages, including segmentation error, which a lot of us run into, artifacts, and there's no automation for change analysis. So for our patient, when we analyze the deep capillary plexus using a 3x3 OCT angiography with TopCon imaging, we can see that there was a flow void along an inferior branch of an arteriole that courses underneath the fovea within the macula. And when correlating this to the en-face image, you can see that along that inferior branch in that deep retina, there is some ischemia that is occurring inferior to the fovea, kind of wrapping around it, inferior macula, which corresponds to that flow void seen on OCT angiography. And if you reflect back on the subjective scotoma that the patient presented with, this inferior branch ischemia in the macula corresponds quite well to what was described as that gray cloud that the patient presented with. Now that we have an OCT angiography, we have a flow void along the inferior macular arterial branch in OCTA, we still want to really hammer home the diagnosis. There's a couple imaging modalities that we can have, and I want to hold the audience to see what you would want to order next. Would you want to order an Optos Y, more of the peripheral retina, fundus autofluorescence, multicolored slow imaging, now getting that IVFA, even though you just got the OCT angiography, or something else?
And while we're running that, Austin, maybe you can tell us what multicolor slow imaging is for those of us who aren't familiar.
Multicolored slow imaging shall be coming up quite commonly in the upcoming slides. Thank you, Dr. Rai.
So you might have given away the answer there. Okay, good.
I like it. Oh, so yeah, go ahead, sorry.
Yeah, so most of your audience wants an IVFA.
Yeah, it looks like IVFA was the main choice. For sure. And hey, that I understand, because that's a very common imaging modality, but we do have a lot of information already from the OCT angiography. We decided to go with something called multicolored slow imaging, which we're going to discuss coming up now. Multicolored slow imaging, SLO, is scanning laser ophthalmoscopy, which is an alternative imaging modality which we can use for fundus photography. For example, on the right here, we have the Heidelberg multicolored slow camera. And this uses 3 excitation laser lights to compose a composite image of the fundus. It uses blue wavelength, which is short wavelength, 488 nanometers, green for intermediate wavelengths, and infrared light as a longer wavelength to penetrate deeper into the retina. And by doing so, it combines the reflectance patterns of all 3 laser lights into one single en-face image with the hope of improving the retinal details in our images. So if we look at the penetration, as we know when we're comparing anterior segment OCT to UBM, the shorter wavelengths only penetrate superficially into tissue. So the short blue wavelength can image the superficial retina. Intermediate green wavelengths can penetrate the middle, and the longer red and infrared light penetrates the deep retina and the RPE. This allows you to combine images in multiple layers into a single en-face image for more retinal detail. So when you have the blue wavelengths, green, and red imaged for a single retina, they're combined into one multicolored slow imaging or scanning laser ophthalmoscopy. So it has a lot of advantages compared to conventional fundus photography or CFP on the right-hand side. It's useful for non-dilated eyes due to the high scanning speed. You have longer wavelength that's able to penetrate through those pesky media opacities that we run into all the time in fundus photography, like cataracts or corneal opacities. And you can montage multiple images together for an ultra wide field image of the patient's retina. And for our patient, even though, as Yusuf astutely mentioned, it was a grossly normal fundus examination, you're using multicolored slow fundus imaging, the green wavelength, which penetrated the middle retina, was able to delineate that Hollenhorst plaque at the arterial bifurcation. And when you superimpose the multicolored slow fundus image at high resolution to the OCT angiography, you can see the culprit, which is causing the flow void on the inferior arterial branch of the macula. So the diagnosis for our patient is an occult BRAO. This is a BRAO which has no frank retinal whitening or edema, but really Ryan's careful OCT imaging analysis that found that there was internuclear outer plexiform atrophy, and correlating that to the vasculature of the retina or the deep capillary plexus was able to allow us to choose OCT angiography as the next imaging modality. And OCTA and on-FOS OCT found the flow void and the subjective scotoma, which the patient presented with. And multicolored slow imaging really helped us hammer home the diagnosis for delineating the plaque. Hollenhorst plaques were first described in 1958, which are refractile cholesterol emboli, which present really in the bifurcation sites of retinal arterioles, causing downstream ischemia and infarction. And these emboli typically are from the internal carotid artery. Therefore, current literature really suggests getting an ipsilateral carotid imaging, as well as a referral to stroke prevention clinic for these patients. Though this referral for stroke prevention clinic is still up for debate, really carotid imaging is the necessity for these patients. So in conclusion, RAOs can present without overt retinal whitening or edema on OCT, but careful OCT analysis correlating that to retinal vasculature can help detect pathology. And the use of OCT angiography, on-FOS OCT, and multicolored slow imaging can help detect these very subtle pathologies. Thank you so much.
That's a fascinating case, Austin. Great pictures. I can see, that original OCT, the subsource OCT, kind of
thank you
made you wonder, but I think the slow images afterwards were just incredible. What you saw there. So thank you for sharing that. You said the stroke workup is debatable. What do you mean by that?
So the current literature shows there's actually not a significant, there's not a significantly higher risk of stroke in 10 years. That being said, there is a significantly higher chance of ipsilateral carotid artery disease. So it does not technically, or does not specifically lead to strokes or ischemic events, but it could preclude you to having carotid artery disease, which obviously we know can lead to stroke. So that's the current literature right now, but really the carotid imaging is the crucial part of it.
Okay, thank you. Thank you for that wonderful presentation. Prem, the floor is yours, my friend.
Alrighty, thanks, Austin, and thanks, Dr. Chowdhury. Technology resident. Thank you to the jury for the opportunity to present today. There are no disclosures related to this talk. So we received a referral, or not we, a few years ago, a referral was received by sick kids for a 9-year-old male with worsening vision for the past 3 months. This 9-year-old male complained of decreased vision over the past 3 months, worsening with each day. They saw 2 optometrists in the weeks leading up to their presentation, and they were diagnosed with astigmatism. And this astigmatism was not correctable with refraction, so the patient was referred to the emergency department. In the sick kids ED, they didn't identify that the child had any headache. On exam, there are no neurologic deficits, and further history taking revealed no emesis, double vision, no other eye concerns, apart from this decreased vision, and no trauma. So they diagnosed the child with painless vision loss, NYD, and asked for a same-day referral to the emergency opto clinic at sick kids. The child was otherwise healthy, didn't have any birth history that was significant, no significant social history, and no significant personal or family ocular history. So on exam, the child had a vision of 20/25 and 20/80 that was not correctable with pinhole. Their pupils were dilated by the optometrist, so we couldn't check for an RAPD, and their pressures were normal. With cyclorefraction, there was a significant improvement in vision, and these are the color testing and contrast sensitivity results. Looking at the anterior segment, it was normal, there were no concerns. And in terms of the posterior segment, these were the fundus photos. So I don't know if someone in the audience wants to describe these fundus photos.
So it's a colored fundus
Perfect,
photo.
thank you.
There's a bit of a dull foveal reflex and some white retinal flecks.
Perfect. That is great. And that's exactly what we see here. You got it, Jackie. So colored fundus photographs of the right and left eye. The media is clear. The optic nerves are relatively normal. And most notably, we see dull or blunted foveal reflexes, white flecks, pisiform flecks around in the mid-periphery, extending onward. And there is a sign here as well, a bronze, beaten bronze metal appearance of the fovea. And these are the retinal flecks there. These are other photos, fundus autofluorescence photos. And Jackie, just because you're on a roll with the first one, do you want to describe these ones as well?
Sure, there's some hyper and hyporeflective flecks, as well as some central macula / fovea hyporeflectiveness.
Perfect. That is exactly correct. So some of these flecks are autofluorescent, some are hyper. And we see here in the central macular fovea, there's hypoautofluorescence signifying atrophic changes. And just that's depicted there. Just moving on. So these here are angiographic images, specifically ICGA, images of the right and left fundi. And just looking at the photos, we can see here centrally, there's some hypocyanescence in both eyes of the central macular fovea, along with a ring or border of hypercyanescence in both eyes. And this is referred to as dark atrophy. Let's just take a sec to learn more about the sign described by Dr. Sarinhi a few years ago.
So Prem, can I
the top
pause
four
you?
panels, if we
Prem, can I pause you there for a second?
for sure.
Can you go back to the previous image? Just go back one slide. Okay. So this is a fluorescein angiogram, not an ICG, although the discussion that you're going to have is excellent. So just because all these things matter, how can we tell from the residents, how can we tell this is a fluorescein and not an ICG? What's the difference between fluorescein and ICG? What should light up first all the way through if it's ICG versus fluorescein?
The choroidal vasculature.
Okay, so the retinal vasculature is the superficial retinal vasculature or the deep retinal vasculature?
So the choroidal vasculature, you would see it more.
That's right. That's right. So when we give ICG dye, it's limited to the choroidal vessels because they cannot cross the RPE area. So we can see the choroid lighting up first, and then we see the retinal vasculature light up. And again, with ICG, it's a choroidal study. So we're interested in choroidal abnormalities, and those are the ones we're more likely to see. So I'm going to let Prem take over. But when we start to look at images like this, sometimes there's so many images that have been captured, it's easy to miss the fact that we're looking at an FA versus an ICG. Go ahead, Prem.
Great. Thanks, Dr. Chowdhury, for that explanation. And essentially just, so these panels here, this was from a paper that was published by Dr. Sarinhi back in 2012. The top four panels are pertaining to the condition we're discussing. Some of you may already know what the condition is, but we'll leave it a little bit of a mystery for those that don't. And then the bottom four panels here are of a patient, we'll call them patient 2 with age-related macular degeneration. The first photos in each row are colored fundus photos illustrating some geographic atrophy and diffuse yellow posterior pole deposits, maybe a little bit more difficult to see in the top panel A here. But there are essentially flecks in patient 1, which is the top row, and in patient 2 here, we see drusen in the AMD patient. These deposits are maybe a little bit more visible with the FAF images we can see here in the second column of both rows. Now, looking specifically at the third and fourth columns of both rows, the third column are intermediate and the fourth column are late, so 6-minute and 40-minute. These are ICG angiography phases. In the top rows here, we can see that the atrophic areas in box C are hypocyanescent, Oops, my apologies. And just later on, moving towards the later phase, we can see that there's a slight ring around the previously early phase or intermediate phase hypocyanescent area where there's some increased hypersenescence. Looking at the AMD patient in the bottom row, we see that the atrophic areas are isocyanescent in the intermediate phase and then slightly hypercyanescent in the late phase. So the absence of normal choroidal hyperfluorescence by FA, sometimes referred to as choroidal silence, has to be differentiated to dark choroid. So
I think we lost. Is it me or is it Prem?
Prem.
Prem. Austin, is he next to you? Do you want to let him know that we can't really hear him? He's frozen there. Oh, maybe have we lost Austin too? No, Austin's there. Austin, you there? Okay.
While he's paused, I'll fill in the gap for that slide. So I asked for him to present this case because as you all go into practice, you're going to have people that are coming in that have had Stargardts for like 30 or 40 years in their eyes. And now they're going to look like a dry AMD patient because they both have geographic atrophy. And now obviously we're in the new era now where geographic atrophy therapies are making their way into the market. How will you differentiate that this is a Stargardt patient that's been Stargardt for many years without, let's say, a great history or genetics from an AMD patient? And that was really what the impetus for this type of investigation was. And so it turns out that on ICG, the chorea capillaris and the choroid are preserved in Stargardt eyes, and therefore you don't get that dark atrophy. Whereas in AMD, the chorea capillaris and part of the choroid is atrophied, and so there's no flow there, henceforth dark atrophy. So there is a way of, while invasive with ICG, to differentiate between the two types of patients because it does affect what counseling you would give the patient. In one case, the patient should have had the disease most of their life, versus in another case, it's an AMD patient, which the therapy and the process is different. So I think that's really the take-home point and the signs for differentiating something that is commonly presents in our office now and can be hard to differentiate with other modalities in general.
And as you said, this question is actually going to become quite relevant as those therapies come, because previously it may have been just an academic exercise, whereas now it may actually have some clinical significance.
Right.
So Prem is back. Let me just bring him back to the
just in time
panel. There you go. Let's just give him a second there. He just wanted to promote his DJ business.
Shameless.
Sorry, everyone, about that, but I heard that what Dr. Chowdhury said, and that's exactly it. Just trying to differentiate the difference between Stargardts and AMD as well as other cases. So just moving on to a couple more imaging slides here. Just for the sake of time, because of that hiccup, I'll just explain. So these are OCT photos. I'm just going to zoom in a little bit here. And essentially what we see here is significant outer layer thinning with ellipsoid zone disruption. And just if you look very closely, there are some tiny hyperreflective deposits at the level of the RPE. And this patient also had pattern ERG and full field ERG testing, which showed macular dysfunction with borderline cone responses. Their visual field testing revealed scotoma centrally, inferior paracentrally, and superiorly. And while we know what the diagnosis is, there is a large differential diagnosis for things such as a bullseye maculopathy, one of which was discussed earlier by Dr. Chowdhury, plaquenil toxicity, but this is just a list and I won't bore you with reading these details. For this patient in particular, Before we found out it was Stargardt's, it was called a retinal or macular dystrophy that we weren't able to confirm yet. But with testing, we found that the patient did have 2 copies of a pathogenic ABCA4 gene, another pathogenic copy of GNAT, and then 1 copy SPATA7, which was a variant of unknown significance. Both parents were carriers for the ABCA4 gene, which is probably how the child got it, of course. In terms of just a quick overview of Stargardt's, it's the most common inherited macular dystrophy. Its inheritance is autosomal recessive. The most common gene, making up 95% of cases, is the ABCA4 gene, while there are other genes that can make up about 5% of cases. Stargardt is usually, it usually starts early on in childhood and peaks in early adulthood, although it can continue to get worse over time, slowly over time. Earlier onset usually means more aggressive disease, while there are later onset diseases as well related to Stargardt. Possible presentations: some patients may present asymptomatically, while some may have metamorphopsia, and others can have progressive decreased central vision, which is classic, as we've seen in this case we're presenting. We discussed some of the fundus findings, and then in terms of testing, while ICGA is great with that hypocyanescent area, which is more frequent in Stargardt's versus atrophic AMD. This finding, along with spectral domain OCT, revealing an intact choroid, suggests possibly selective damage of the choriocapillaris in Stargardt's, as we discussed earlier. Of note, with the advent of fundus autofluorescence, better OCT imaging, ICGA is not commonly used anymore, not to mention the expense associated with obtaining the dye. In terms of treatment, their treatment options right now for Stargardt are quite limited. We do recommend some non-pharmacologic therapies, such as just protecting one from sunlight, while blue light filtering glasses can be a bit contentious in the ophthalmology world. Given that blue light may be toxic to the retina, it is something that is recommended in certain conditions such as Stargardt's, based on, depending on the provider, and it's recommended that they're not exposed to smoking. Antioxidant supplements and dietary vitamin A are also recommended. In terms of pharmacologic therapies, there is a lot of research right now on metformin, other retinol binding protein agonists, and there's amoxicillin HCl inhibition of RPE65. And then hopefully one day, if it is possible, and there are studies that are, again, looking into this, RPE transplantation. So far, nothing significant, but trying to figure out ways to prevent this, what right now is a irreversible progressive visual disease. So that is it. Thank you so much again to everyone, specifically the patients who allowed us to use their images in this presentation, Dr. Aon and Vincent for seeing these patients, the Sick Kids imaging team, and to the department and Dr. Chowdhury for the opportunity to present today.
Yep.
Great
I think Dr. Epstein had a question in the chat about which had the darker appearance, AMD versus Stargardt. So just again, to reiterate, with AMD, you get the dark atrophy because of the loss of the choriocapillaris and choroid, whereas in Stargardt's, it's preserved and you do not get that phenomenon.
Thank you. RPE transplantation. So you may not know much about that, Prime. I'm sure you haven't seen it, but maybe Nathan or Prime, where's a donor RPE coming from?
The same patient.
Same patient. Okay.
They're taking a piece of the peripheral retina and doing a biopsy basically, and then lasering that peripheral area closed, and then transplanting it. But I'll say, particularly for Stargardt's, actually, vitamin A is now a target. Vitamin A is obviously believed to be sort of involved adversely in the development and progression of Stargardt's disease. So the current process and thinking is to use gene therapy at the level of even a systemic administration to limit the liver's production of vitamin A as a means of potentially dampening the progression of this condition.
Yeah, so just a question here, actually, Phil, in the same point. Prem, you mentioned vitamin A supplementation, and I'm just hearing like some recent reports that actually vitamin A supplementation can be harmful for Stargardt disease.
Yeah.
So if you can allude
Yeah.
more to that, that would be like, what do you
Yeah,
think?
so, yeah, the vitamin A right now is not something that would be highly recommended for this condition. A lot of that is historic and it does pertain to RP. And I think sometimes these things get lumped together where all degenerations should benefit from the same vitamin supplementation. It's not true. You're correct. So vitamin A would not be something to be advising these patients. Pretty much macular carotenoids, you know, the lutein, zeaxanthine, mesozeaxanthine formulations are good pretty much for any retinal condition, particularly degenerations. And then obviously, you know, limiting UV light exposure. But for now, the goal is to change their genetics.
Okay, well, that was fascinating. Thank you, Prem and
There
Austin
are actually two separate.
and Nathan Chowdhury for the wonderful rounds this morning, kicking off our academic year. Next week's rounds will be presented by Dr. George Nasrallah, who's a new oculoplastic surgeon who's just started practice at Mount Sinai Hospital and the university. So I look forward to welcoming everyone back for that. Enjoy your Friday, everyone. Thank you again to the presenters.
Thank you.